Thank you. Well, good afternoon. So what I thought we could do is, actually it looks like my titles are getting cut off, but I thought we could go over the background first on maintenance therapy and discuss terminology since it's relatively new in the NCCN guidelines. And then we'll focus mostly on the switch maintenance trials, SATURN and JMEN, and then do the continuation maintenance studies with an update about POINTBREAK, which, as everybody knows, has been a topic of major discussion in thoracic. But beginning first with terminology, we have two terms now in maintenance therapy: continuation maintenance or switch maintenance. Obviously, continuation maintenance means that you use the drug in the front line as part of your original induction. And then if you do switch maintenance, it's not part of your original induction. So examples of continuation maintenance is bevacizumab. Examples of switch maintenance would be if you give a platinum doublet for 4 cycles of therapy and switch over to erlotinib. Okay. So this is a summary table of some selected maintenance trials that I put together. And you can see pretty much across the board that there's a lot of studies that show progression-free survival benefit. Now, I didn't put toxicity or quality of life analysis on here, or cost. But certainly this will be a topic of discussion a little bit later with Dr. Langer. In terms of overall survival benefit, it's been a little bit more controversial, but certainly we do have 2 agents now that are FDA approved for switch maintenance, and then we'll talk about continuation maintenance next. So to begin with, in terms of switch maintenance, and I know I'm going very quickly through this, so if anybody has questions, please feel free to interrupt me at any time. But when we look at the switch maintenance studies, SATURN and JMEN, we'll begin first with SATURN. This was a trial that gave platinum-based doublet for 4 cycles of therapy, and in the patients that didn't progress, they were randomized to erlotinib versus placebo. Now, there were 2 co-primary endpoints: progression-free survival in all patients, and then progression-free survival in the patients who had EGFR IHC-positive tumors. Now, the bottom line to these trials was that there was a progression-free survival benefit for all patients across the board for the intent to treat. The hazard ratio 0.71, the p-value highly statistically significant, favoring the erlotinib maintenance. When you looked across the board at all histologic subtypes, both for adenocarcinoma and squamous cell carcinoma, there was a progression-free survival benefit, hazard ratio 0.6 for the adenos, and then 0.76 for the squamous cell carcinomas, all statistically significant. Now, let's talk about mutation status, which is going to be our future, but when these trials were designed, the molecular phenotyping wasn't as defined as it is now. But when you look across the board at both wild-type EGFR, you can see that there is still a progression-free survival benefit with erlotinib maintenance. So this is not something that you just do for the mutants, okay? The hazard ratio for the wild-type EGFR patients was 0.78, the p-value highly statistically significant. Now, there is a greater magnitude of benefit, obviously, in the EGFR mutated patients that have sensitive mutations, the L858, the deletion exon 19. Their hazard ratio was 0.1. Now, you rarely see this in lung cancer. So it's very critical in your EGFR mutated patients to get them an EGFR TKI, if they have a sensitive mutation, in as early as possible. And so if you, for instance, don't get their mutation status back, you gave them chemotherapy, erlotinib is very appropriate to go to as a switch maintenance regimen. Now, more often than not, these patients are going to get the EGFR TKI frontline and not see any chemo. But if you do, for whatever reason, have a patient on chemo already, you get their mutation status back later, switch maintenance to erlotinib would definitely be appropriate. Now, from the SATURN trial, there was no new safety signals. Obviously, rash and diarrhea, don't worry, there's no photos during lunch. So rash and diarrhea are the most common side effects denoted. Now, the overall survival results. It's always difficult looking at overall survival now in lung cancer because oftentimes these patients have 2nd line, 3rd line, 4th line, 5th line therapy, and unless you collect that data, it's hard to ascertain whether or not a patient truly, there is a survival difference. But when they looked at the intent to treat population and then the EGFR wild-type populations, there was an overall survival benefit for the erlotinib treated patients with maintenance, the hazard ratio 0.81. P-value highly statistically significant, and for EGFR wild-type, again, the p-value 0.02. So let's talk about the JMEN study, switching over to Pemetrexed maintenance. So this, again, was similar in design with a platinum-based doublet for 4 cycles of therapy, and the patients that did not progress, they were randomized to Pemetrexed maintenance versus placebo. Now, the primary endpoint was progression-free survival, and obviously since we're discussing it, there certainly was a progression-free survival benefit as well as overall survival benefit favoring the maintenance Pemetrexed, both p-values highly statistically significant. Now, when we come to histology, though, obviously everybody in the room is well aware, Pemetrexed is very effective in non-squamous cell carcinoma. It does not, however, work in squamous cell carcinoma. The reason is, the thought is that there's intrinsic mechanism of drug resistance because of high levels of thymidylate synthase in the squamous cell carcinoma patients. So don't give maintenance Pemetrexed to squamous cell carcinoma. It's really only for non-squamous, non-small cell carcinomas. In terms of the safety profile for the Pemetrexed maintenance, obviously there's a little bit more side effects to the Pemetrexed compared to the placebo. That's all highlighted here. None of these really reach significance, though, in the analysis. And so what I would say is that we have these two agents that are now FDA approved for switch maintenance, both the erlotinib and the Pemetrexed, after 4 cycles of a platinum-based doublet. Now, let's talk about Pemetrexed in the situation of continuation maintenance, and that's the PARAMOUNT trial. We'll then be discussing bevacizumab in 4599 and the POINTBREAK study. But for the PARAMOUNT study, this again was a trial that was giving cisplatin Pemetrexed for 4 cycles of therapy and then randomizing patients to maintenance Pemetrexed versus maintenance placebo. Now, the PS of these patients was ECOG PS 0 to 1, so very good population, who pretty much did have a stratification for PS 0 to 1. So, wow, you really can't see this at all. Okay, take my word for it. Patient characteristics were well balanced between the two arms, and in terms of compliance, there was actually a little bit more or higher benefit to the patients who were getting the, in terms of compliance. They were more compliant with the Pemetrexed than they were with the placebo. And in terms of treatment discontinuation, it was 18% in the Pemetrexed arm versus 7%. For a second, I thought it was my vision is going as I'm standing up here. But when we looked actually at the difference between subsequent therapy, it was pretty well balanced between the two treatment arms. And so certainly overall survival results, I think, are very reasonable to look at in this trial. So when we look at final overall survival results from the time of randomization, the hazard ratio was 0.78 and the p-value highly statistically significant. When we look at overall survival from point of induction, it was also highly statistically significant, and the hazard ratio was favorable to the Pemetrexed arm at 0.78. Now, when we look at the overall survival subgroup analysis, pretty much everybody across the board for all clinical characteristics got a benefit from the Pemetrexed maintenance. There wasn't one that didn't. So when we actually look at overall progression-free survival as well, both as the primary efficacy endpoint and then reassessed at time of final OS, it was still positive for progression-free survival benefit for the intent-to-treat population on this trial. What about toxicity? Well, there was a little bit more fatigue, anemia, as well as neutropenia in the patients who got the maintenance Pemetrexed versus placebo, to be expected. But what I could say, what we can say from this PARAMOUNT trial is that patients who got the continuation Pemetrexed maintenance certainly had an improved survival over placebo. All subgroups seemed to have a survival benefit. The response to induction therapy actually didn't seem to be predictive for the survival outcome. You know, we've heard a lot that oftentimes in the SATURN trial, the patients who had stabilization of disease actually got the best benefit from maintenance erlotinib. Well, we didn't see that that was the case in the PARAMOUNT study. Certainly, continuation maintenance Pemetrexed can be accepted as a standard of care. I personally like to do that if I'm giving a platinum Pemetrexed. I will often continue Pemetrexed maintenance in an appropriate patient. Okay, let's turn now to bevacizumab. So we'll talk about two trials, E4599 and the POINTBREAK trial. Everybody's familiar with E4599. This is carboplatin paclitaxel with or without bevacizumab. This was one of the very first targeted therapy trials in the frontline setting that had a survival benefit. Obviously, there were eligibility criteria that you don't give bevacizumab to patients who are actively bleeding, have hemoptysis, have uncontrolled brain mets, and that is still consistent even now. Now, the bottom line to E4599 was that there was both a response rate, progression-free survival, and overall survival benefit across the board. There was about a 4% risk of hemorrhage with the addition of bevacizumab, but the belief was that you know, it's offset certainly by the survival benefit. And so this has been adopted as a standard of care practice to give continuation bevacizumab after you give the triplet of carbopaclitaxel bevacizumab. Now, I told you that to basically discuss this trial, the POINTBREAK study, which nobody can really read. Okay, so this was the E4599 regimen, just trust me, and this was the carbopaclitaxel bevacizumab followed by bevacizumab maintenance, and it was being compared to carboplatin pemetrexed with bevacizumab. The dosing was of the bev was 15 milligram per kilogram, IV Q3 weeks, the carbo AHC 6, and the pemetrexed 500, just standard. Now, in the maintenance section of the carbo-pem-bev, you gave pem-bev as maintenance every 3 weeks. So this was the two arms that were being compared. And the bottom line was they enrolled 939 patients, very large randomized trial. They just presented this data at the Chicago meeting and also ESMO. The bottom line was there was no major difference in response rate, progression-free, nor overall survival. There was actually a higher toxicity reported in the pemetrexed bevacizumab arm, with anemia requiring more blood transfusions as well as thrombocytopenia. Now, the E4599 regimen actually had more neuropathy and alopecia. So these two regimens appear to be equivalent in efficacy, but just different toxicity profiles. We don't have any data yet about specific molecular subtypes or any type of clinical characteristics that might benefit more from one to the other. So right now, equivalent efficacy, but different side effect profiles. So you should choose for your patients based off of that. Now, there is a very important trial I want to highlight that's E5508. Because one of the biggest criticisms is, what do we do when we're giving the induction, and then what do we do in the maintenance? Has there really been anything that's shown that 2 agents in maintenance is better than 1? And so this trial is designed to specifically look at that issue. And this E5508 shows carbopaclitaxel Avastin every 3 weeks for 4 cycles of therapy. And in the patients that don't progress, they are randomized to one of the 3 maintenance arms: bev alone, pemetrexed alone, or the pemetrexed bevacizumab. Their primary endpoint is overall survival, and this is being run by ECOG. So we're waiting for the results of this that might help define whether or not we really need to continue 2 drugs in the maintenance, or if we could get away with just 1. Okay, so what are my conclusions about maintenance therapy? At this time, there are 2 FDA-approved agents for switch maintenance, pemetrexed and erlotinib. Pemetrexed should only be given in the non-squamous cell carcinoma patients. Continuation maintenance with pemetrexed as well as bevacizumab have both been established by the PARAMOUNT and E4599 and now POINTBREAK trials. The efficacy of combination doublet maintenance over monotherapy maintenance will be assessed in E5508. So we'll get more information from that trial. Certainly, there's been a lot of studies looking at gemcitabine and docetaxel maintenance. My comment on it, and the reason I didn't show it to you, is that, there's issues with quality of life and toxicity as well as convenience. I think we have plenty of other agents that work that you don't necessarily need to utilize the docetaxel or gemcitabine as maintenance. There's a lot of studies that have looked at these. I just think toxicity is too high, and I also think having somebody come in for weekly maintenance is just really prohibitive. There are certain subgroups of patients that may derive significant benefit. Obviously, molecular profiling is going to be our future, and we're going to know a little bit more about which patients respond the best depending on their mutation profile. And molecular biomarkers certainly require additional validation. And I'll leave you pretty much with my treatment algorithm for what I do in the clinic in thoracic. So if you have a non-squamous cell carcinoma patient and they're neuroendocrine, I still like to use platinum etoposide, and I will do switch maintenance to either pemetrexed or erlotinib based off of what my patient would prefer. If they are an adenocarcinoma and they're an EGFR mutant, I always give EGFR TKI frontline, but if I inherit a patient who got chemo first, I always do switch maintenance right away over to erlotinib. If they are EML4 ALK or ROS1, they get crizotinib. If they are EGFR wild type for frontline, my preference has always been platinum pemetrexed with or without the bevacizumab, depending on their situation if they're bev eligible. I do like that because in my clinical experience, I haven't seen the toxicities that they reported in POINTBREAK. Also, you don't get the neuropathy, you don't get the alopecia, and the patients, for me at least in my clinic, have always been able to tolerate this regimen very well. Now, if they are not bevacizumab eligible, or for whatever reason you don't want to do PEM in the front line, very appropriate to do a platinum-based doublet for 4 cycles of therapy and do switch maintenance over to the erlotinib or the pemetrexed. Also very appropriate to do platinum pemetrexed followed by continuation pemetrexed maintenance in your adenocarcinoma EGFR wild-type group. In your squamous cell carcinomas, avoid the Pemetrexed, avoid the bevacizumab frontline. You shouldn't be giving them to squamous cells. You give a platinum-based doublet. My go-to regimen is cisplatin docetaxel, 75 milligram per meter squared of both agents, 4 cycles of therapy, and then I do switch maintenance over to erlotinib in patients that wish to continue treatment. Now, with that said, I am going to put one caveat up there, and this is my projected future algorithm for what we're going to deal with in the adenocarcinomas. We're going to also have one for squamous cell carcinoma. And yes, maybe I am optimistic, but I do believe that we're going to one day find a driver mutation for all of these patients, and we're going to be able to give them all a targeted agent to keep their cancer controlled, and then rebiopsy them when they develop resistance and give them an appropriate agent based off of the resistance mechanism. And in the end, the chemotherapies will be saved mostly towards salvage therapy at the very third and fourth line treatment. So I think I'm going to just stop there, and I guess we're supposed to go to the question next.